Sir, shall I start? It's 8:45. Am I audible, Akshay? आवाज आ रही है?
Yes, sir, audible.
Okay. Bala sir, shall I start?
Yeah, please start. Please start. Please start.
Yeah, just now your mic is on. It was off. Okay, thank you, sir. So, good evening, and I welcome you all to this PG Clinics by Durg Bhilai Academy of Pediatrics. I welcome our expert, Dr. S. Balasubramanian, sir, from KKCTH, Chennai. And I also welcome Dr. SEEMA JAIN, consultant pediatrician and nephrologist from District Durg Hospital. And I also welcome our presenter today, Dr. Akshay, who is a DNB first year resident and from Sector 9 Hospital, Bhilai. And I also welcome all our respected seniors and my dear colleagues and my dear junior friends, all the postgraduates from across Chhattisgarh. So Dr. Akshay is going to present a very nice case today of a newborn with jaundice. So I request him to please go ahead with your case presentation.
Yes, sir, thank you. Good evening, sir. Good evening, ma'am, and everyone else. Myself, Dr. Akshay, first year resident from Sector 9 Hospital, Bhilai. Here I am going to present a case, a baby of Mrs. XYZ, who was born on 1st of August 2023, and I am examining the case on 2nd September 2023 at 30 days of life of the child. It is a female child, a localite hailing from Durg, Chhattisgarh, and the informant is mother, which is reliable. Socioeconomic status is upper middle class. The chief complaint was yellowish discoloration of skin and mucous membrane, noticed 24 to 48 hours back, as according to the mother. And this was about 10 days after being discharged from the neonatal unit with similar complaints. History of presenting illness. Baby was apparently looking all right 48 hours ago, after which mother noticed yellowish discoloration of skin, which progressed from initially involving only the face to now involving both the limbs. There is no history of clay-colored stools and dark staining urine, no history of lethargy, seizure, high-pitched cry, poor feeding, no history of any birth trauma, no history of repeated vomiting in the child, no history of delayed passage of meconium, no history of breathing difficulty around birth, no history of any fever. In past history, there was...
One minute, Dr. Akshay, Dr. Akshay.
Yes, sir.
Please go back to the previous slide. See, first slide, go to the first slide.
Yes, sir.
Presenting complaint. Go to the previous slide. Yeah. What is the presenting complaint?
Actually, the child presented with yellowish discoloration of skin and mucous membrane on 30th day of life.
30th days. That is after noticing jaundice, the parents have brought the child within 24 hours. Is that right?
Yes, sir.
Okay. Now, you have added one sentence which says about 10 days after being discharged from the unit with similar complaints.
Yes, sir. 10 days earlier, child has similar complaint for which child was admitted in our hospital and was treated.
And is treated and discharged. Okay.
Yes, sir.
Now, I want to know from you, when did the illness start in this infant?
The illness started at birth, sir. Few hours after birth.
At birth. Then why are you starting the history from yesterday?
Okay.
You are getting my point?
Yes, sir.
And you are saying the chief complaint is jaundice noticed only 24 to 48 hours. That means the baby did not have jaundice at all before?
Baby had, sir.
Baby had. So where should you start the history?
From birth.
From birth. Now,
yes, sir.
This is what, see, sometimes we always, youngsters, you youngsters, not we, you youngsters, you always have a tendency to put the blame on the mother, saying that this is what she said. The mother may not know the importance of the problems in the history,
Yes,
right?
sir.
So
Yes, sir.
you should not say mother told me jaundice started only yesterday, so I am starting here. So where should you have started the entire history?
I should have started from birth.
Absolutely, absolutely. Now you want to correct yourself and start, forget the slides that you have put.
Yes, sir. Actually, the child presented with yellowish discoloration of skin and mucous membrane few hours after birth, around 6 to 8 hours after birth.
How many hours after birth?
Just 6 to 8 hours after birth.
Which you had put in the past history. Now go back to the slide on past history. That becomes
Yes,
present history to me today. Yeah. Okay. You get my point?
Yes, sir, I got it.
Yeah. Yeah.
So there was clinical jaundice developing after about 16 hours of life with a serum bilirubin of around 8 milligram per deciliter and was formally investigated, then given phototherapy. The TSP which returned within normal limits within 70 hours of life and was discharged later. Followed by which a second hospital admission on 15th day of life with similar complaints was there, wherein the serum bilirubin was 15 milligram per deciliter. Child was otherwise active. Child was again investigated, treated accordingly, and discharged on 21st day of life. And this was the third visit at present on 30th day of life.
Now, what does this history tell you? And what is lacking
Yes,
in the history? What is lacking in the history?
history tells me that the jaundice presented within 24 hours of life, most likely a pathological jaundice.
Okay,
And
it is likely to
even
be.
of
Yeah, 100%. This is any jaundice appearing within 24 hours. Absolutely right. You are. It is pathological jaundice. That is one. Second,
and even after treatment, there is a recurrence of jaundice.
no. I want to know from you: did the jaundice completely go off?
No, sir.
Then where is the question of recurrent jaundice? Is it recurrent jaundice or persistent jaundice?
Persistent jaundice.
Persistent jaundice. See, that is again history. See, our parents, may only tell you that the jaundice has disappeared, or may even wrongly tell you it has disappeared. But
Yes, sir.
from the story, do you think the jaundice would have disappeared and come back? You don't get
No, sir.
recurrent jaundice in the newborn period. You get it's very unusual.
No,
Okay.
sir.
So this is persistent jaundice from 16 hours of life. Right?
Yes, sir.
And the other thing is, second time investigated and treated accordingly. What accordingly? What treatment is given?
Phototherapy was given, sir.
Phototherapy. Okay.
Yeah.
Third visit now. Third visit. How was the baby? What happened to the jaundice with treatment?
Clinically, the jaundice, the intensity of the jaundice subsided. Tick intensity subsided, and the serum.
What I want to know, from 16 hours of life till now, the jaundice is remaining the same.
Yes, sir.
Or it has gone and come back, or it tends to come down, then again the jaundice increases. What is the story that has happened? That's what I want to know from you.
It tends to come down and then rise again, sir.
Okay. Yeah, go ahead. Yeah. Go ahead.
Okay.
No. Before maternal history, that's all. Your present history is over.
No, sir. Still there.
Yeah, what are the other important points in the present history I would like you to say? First of all, you should have started with the birth weight and the birth details.
Okay, sir.
What is the birth weight of the baby?
Birth
Don't tell me.
weight of the
Yeah, this is where you should have started the entire history with jaundice. What is the birth weight? 2.8 kg. Now
2.8 kg.
Now give details.
Birth weight of the child is 2.890 kgs. The child passed urine and meconium at birth. Breastfeeding was initiated within 30 minutes of delivery in the labor OT. Child was given feeds on demand. There was no supplementary feeding. Child passes urine around 7 to 8 times a day and stool of around 3 to 4 times a day. Baby sleeps normally for about 1 to 2 hours after feeding and wakes up crying.
Go ahead. Is that all? Is that all? What is missing in the history, in your postnatal history till now? What other important history you should have asked for? Something related to the growth of the baby. I'm giving you a clue. Did you ask about the weight of the baby after birth? What happened to whether there was weight loss, weight gain,
Yes, sir.
or no weight gain at all?
Yes, sir. I have asked.
What details did you get?
Actually, there was weight gain. Initial 10 days, there was.
How much is the weight gain? I'm not asking about antenatal period. I'm asking about the baby's weight gain. Birth weight is 2 kg. What happened to the weight?
Sir, at present.
No, not in examination. From the history of the
Okay,
mother.
sir.
You don't go to the examination.
Okay, sir. Birth weight was around 2.8 kg and the present weight was 3.67 kg. Initial 10 days, there was normal.
That you should have mentioned in the history. Go back to the history. You should have mentioned about the weight gain of the baby. But that is going to give you information. Yes or no?
Okay. Yes, sir.
Wait. Then what else? What else? What else? Everything is negative history. What else you should have asked for? Well, you said that there is no history of clay-colored stools and dark urine, indicating that the hyperbilirubinemia is probably
indirect
or unconscious.
Indirect.
Okay.
Yes,
And
sir.
rest of the negative history you have mentioned, right?
Yes, sir.
Fine. Any abdominal distension?
No, sir. No abdominal distension.
Okay. Any pallor noticed by the mother?
No, sir.
No. What are the medications the baby received?
Baby hasn't received any medication as such, sir.
That you should have mentioned. Now complete the remaining history.
Okay, sir. In maternal history, mother is 25 years and it's a non-consanguineous marriage. She's a primary gravida. Mother blood group was B positive. All the pre-pregnancy weight, height, BMI were normal. Mother is a housewife. There is no past or family history suggestive of any hemolytic disease, jaundice, splenectomy, liver disease, anemia, or diabetes mellitus in mother. Paternally, father was 29 years old, blood group B positive. He's working in a private firm. No past history or family history suggestive of any hemolytic disease, jaundice, splenectomy, liver disease. No history of G6PD deficiency in the father. And in Italy, it was a spontaneous conception. Birth order was 1, confirmed by UPT. It's a booked case. 3 antenatal visits were there. There is no history of taking any drugs as such during pregnancy in the mother. First trimester dating scan was done, folic acid was taken. No history suggestive of fever with rashes, lymphadenopathy, excessive vomiting, exposure to drugs or radiation in the mother. In second trimester, quickening was felt normally. Iron, folic acid, calcium supplements were taken. Anomaly scan was done and was normal. TD 2 doses were taken.
Normal first and second trimester, third trimester.
Third trimester is also normal.
In the third trimester, anything?
No history suggestive of any leaking PV or any features of sepsis.
So essentially, all the 3 trimesters have been uneventful.
Yes,
okay, nothing significant had happened. No history of drugs in the mother, right?
No,
fine.
Sir.
Right. Go ahead.
Natal history was a term delivery born by LSCS due to non-progression of labor, and the gestation age was 37.5 weeks.
Did you ask whether the mother received oxytocin or not? Why is it?
Mother received.
Why should you ask that?
Oxytocin being an enzyme inducer.
Oxytocin is one of the risk factors for neonatal hyperbilirubinemia. Okay,
yes,
right.
Yes, sir. Postnatal history we have discussed. Child received immunization as per schedule. Hepatitis B, OPV 0 dose and BCG were given. Injection vitamin D was given. There is no family history suggestive of anemia, jaundice, gallstone disease, splenectomy, or liver disease as such in family.
Okay, just madam, before we go to the summary, Madam SEEMA Jain, you can ask, madam.
Yes, sir. Yeah.
Ask questions before.
Sir, I would like to know whether she was primary gravida or any history of, like, was she primary?
Yes, ma'am. She was priming.
And so there was no bad obstetric history, right? And
No,
weight
ma'am,
gain
no.
was good throughout the pregnancy.
Priming.
Okay.
Yes, ma'am.
Anything else
Like,
you want?
yeah, initially you mentioned that the bilirubin was 15, and then there was rise in bilirubin, you said, right? 8 milligram
Yes,
and then 15 milligram.
Yes, ma'am.
Yeah, I would just like to know, okay, this total bilirubin, you must have gone through the records. So what was the differentiation, differential, conjugated, unconjugated, was that mentioned there?
It was unconjugated.
It
Indirect
was
was right.
unconjugated, right?
Yes, ma'am. Yes,
Yeah.
ma'am.
And male baby, this case is a male child.
No, female.
It's a female child.
She is a female child. Okay.
Yes, ma'am.
Right.
Okay,
That's-
now give a summary of this, and then we'll discuss.
It's a case of 30-day-old baby girl on to non-consanguineous marriage by LSCS, cried immediately after birth, exclusively breastfed and adequately immunized, with neonatal hyperbilirubinemia noticed on day 1 of life, presented again with yellowish discoloration of skin up to palms and toes without any ABO or RS incompatibility. Most likely a case of neonatal unconjugated hyperbilirubinemia, pathological in nature.
Okay, now two or three things. One, in your summary, you should have clearly mentioned about the weight of the baby. Because if the baby is gaining weight and jaundice is like this, you have different etiology. On the other hand, the baby is not gaining weight, failing to thrive, you have different etiology. Okay, now let me ask you that question. Suppose the same story.
Yes, sir.
There are two babies. Same story. What looks like an unconjugated hyperbilirubinemia.
Yes,
Okay.
sir.
One baby is not gaining weight at all.
Yes, sir.
Another baby like this has gained weight normally. What is the difference in terms of the etiology?
A similar baby with failure of gain, failure to thrive, I would suspect of congenital hypertrophic pyloric stenosis.
Pyloric stenosis. Or will you suspect pyloric stenosis in the absence of vomiting?
No, sir.
In other words, you have two babies. One baby who doesn't have failure to thrive but has got unconjugated hyperbilirubinemia. Another baby who's got failure to thrive. Other than congenital hypertrophic pyloric stenosis, what are the other causes you will think of? That's my question to you.
Diseases like liver diseases like galactosemia, thyrosinemias.
Okay. See, remember,
Alcohol.
first of all, the most important statement you must make is that any baby who's failing to thrive who has hyperbilirubinemia, the hyperbilirubinemia is pathological.
Okay.
On the other hand, if the baby is gaining weight and has got unconjugated hyperbilirubinemia, the most common cause is breast milk. Breast milk jaundice or exaggerated physiologic jaundice.
Okay.
Okay, that is number one. Second is, other than hypertrophic pyloric stenosis, there are several other conditions which cause increased intrahepatic circulation, which includes any congenital intestinal obstruction, which includes ileal atresia, okay, Down syndrome, Hirschsprung's disease, etc. Okay, they can also cause failure to thrive.
Okay. Okay.
Inborn errors of metabolism. Of course, it doesn't cause unconjugated hyperbilirubinemia. It causes more often a conjugated hyperbilirubinemia. Right? This is unconjugated hyperbilirubinemia. Occult infection can always cause both conjugated as well as unconjugated hyperbilirubinemia. Okay. Other than that, unconjugated hyperbilirubinemia causing the association with failure to thrive is very, very unusual. Unless you're going to think of something like a very severe hereditary spherocytosis where the baby has developed severe anemia, along with that has developed unconjugated hyperbilirubinemia. Okay, most of the conditions which cause unconjugated hyperbilirubinemia in children, young infants, they are all mostly, okay, not associated with failure to thrive. On the other hand, Any conjugated hyperuremia more often is often associated with failure,
Failure to thrive.
failure to thrive.
Okay, sir.
Okay. Now, you are saying presented again with yellow discoloration, or do you think that statement is correct?
Prolongation of
No, do
symptoms
you think the jaundice disappeared and came back, or the jaundice is persisting?
persisting.
Yeah, so you should have removed the term presented again. Presented
Yes,
again. Okay, now
Okay, sir.
a 30 days old infant, no RH or ABO incompatibility, no failure to thrive, first
Yes, sir.
infant, no consanguinity,
Yes, sir.
unconjugated hyperuremia, which is not coming down, right?
Yes,
What
sir.
do you think are the causes?
I would suspect of other causes of
What are the conditions in which you get prolonged unconjugated hyperbilirubinemia in a 30-day-old infant? What is the differential diagnosis?
breastfeeding jaundice, sir. Breast milk jaundice.
Now, let me ask you, do you think this is breastfeeding jaundice?
No, sir. There is good weight gain.
Good weight gain, does it not occur in breastfeeding jaundice?
Um,
Excellent weight gain will be there in breastfeeding jaundice. Baby will not fail to thrive. There will not be any problems with weight.
okay.
Okay?
Okay.
It can still be breastfeeding jaundice because the baby has otherwise been there. This is where, in addition to jaundice, you should have mentioned that the baby has been essentially well. It is not a sick neonate. You could have mentioned that the activity, feeding, sleep pattern, everything had been essentially normal. But for jaundice, nothing else was happening in the baby, indicating that this is not a sick infant. It could well be, other than breastfeeding jaundice, what are the other possibilities?
Breast milk jaundice, sir.
Breast milk, other than breast milk jaundice.
It could be cholestasis.
What's the difference between breastfeeding jaundice and breast milk jaundice?
Breastfeeding jaundice is due to a faulty feeding, poor reduced frequency of feeding, whereas breast milk jaundice is due to substances in the breast milk which have some glucuronidase like action.
Hormonal transmission from the breast milk, pregnant, diol, etc., causing breastfeeding jaundice. Okay,
Yes,
right.
Yes, sir.
Yeah. Any other conditions?
Cholestasis could be a cause.
Do you think cholestasis is causing unconjugated hyperuremia?
No, sir. No.
Do you think this baby has got cholestatic jaundice or not?
This baby has more of unconjugated, so
More of means that means there is also some conjugated.
Yes, sir.
From the history that you have given, no normal color urine, normal colored stools, only jaundice. This is likely to be unconjugated hyperbilirubinemia. When it comes to unconjugated, other than breast milk jaundice, what are the other conditions which cause unconjugated hyperbilirubinemia in a 1-month-old infant? That's my question.
Ongoing hemolysis like in G6PD deficiency.
Hemolytic anemia. Do you think this is G6PD deficiency? I am saying this is not.
It's a female child.
Excellent. It's a female infant, so you need not think of G6PD.
Okay.
If G6PD is not there, if it is a male infant, what other defect will you think of?
Hereditary spherocytosis or other RBC membrane defects. Pyruvate kinase deficiency.
This is hereditary spherocytosis.
It could be, sir.
It can be, but only thing is, if it is hereditary spherocytosis, some family history might be there because it's an autosomal dominant disorder. History of polycystectomy may be there. Okay. Organomegaly with the mother giving history that there is abdominal distension may be there. And pallor. The mother might have noticed pallor or the physician might have noticed pallor. These are all the points which would have made you think of G6P. I mean, sorry,
Hereditary spherocytosis.
What are the possibilities?
Cause of like extravasated blood in case of cephalomatomas.
Cephalometoma, excellent. Extravasation like cephalometoma. Very good. Concealed bleeding somewhere. Okay. Anything else?
Congenital untreated hypothyroidism.
Excellent. Hypothyroidism. what is the type of jaundice or hyperemia you get in hypothyroidism? Why do you get that hyperemia? Why do you get hyperemia in hypothyroid? What is the pathogenesis of hypothyroidism causing hyperbilirubinemia? Anybody can put in the chat box. See, very important points that you must remember with regard to hypothyroidism and hyperbilirubinemia. One, you must remember that hyperbilirubinemia in hypothyroidism is often unconjugated. Often, I'm using the word often.
Okay.
But cholestatic jaundice also can occur in hypothyroidism. That's not common. The reason why you get unconjugated hyperemia is because of increased hepatic circulation.
Okay.
But there is interstitial stasis. But you can have cholestatic jaundice, right? That is hypothyroidism.
Okay.
Right? Other than hypothyroidism, what other causes you will think of when there is prolonged unconjugated hyperemia? You said spherocytosis, G6PD, hexokinase, then hypothyroidism. What else?
Syndromic Crigler-Najjar, Gilbert syndrome.
Here in the history, you could have elicited that the baby does not have any dysmorphism for you straight away to rule out Down syndrome. Anything else?
Yes.
Anything else?
GA obstruction like malrotations.
Yeah. In which case there will have been some symptoms and failure to thrive would have occurred. It is not there in the baby. Anything else? High doses of vitamin K, even high doses of aminoglycosides, neomycin, etc., can also cause unconjugated hyperemia. Even your sulfonamides and this ceftriaxone, okay, they can all cause hyperemia. Drug history.
Okay.
That is very important. Anything else? Okay. Anything else? So, what do you think is the cause for the unconjugated hyperemia in this infant? In fact, from the history, you could have even obtained the levels of bilirubin from the mother.
Yes.
Last, anything else? Any other? Any other? See, in your part of the country, what other disease? I'm giving you
Thalassemia, sickle cell anemias.
sickle cell or sickle thal trait combination could very well be causing this sort of hyperbulimia in your Chhattisgarh.
Okay.
Madam, you want to add anything? Dr. Seema? History. Madam?
Yes, sir. I think everything has been covered very nicely, sir. So, as you said, sir, sickle cell and thalassemia, though we are seeing mothers suffering from these diseases, but neonates don't present with neonatal hyperbilirubinemia in early life, sir. Mostly
Okay.
later, sir.
Okay. Can this be intrauterine infection?
Yeah.
Dr. Akshay, can the whole thing be intrauterine infection?
Could be, sir, but intrauterine infection like thoughts usually present with conjugated type of hyperbilirubinemia.
Yeah. You don't get prolonged unconjugated hyperemia in intrauterine infections. Okay, all of them cause conjugated hyperemia. Again, failure to thrive will be there. Here, baby is thriving very well. Unlikely. Okay. So last, could this be a inspissated bile syndrome? Because baby has been receiving phototherapy.
Can be, yes, sir.
No, unlikely. The reason is at no point of the history there is any suggestion that this hyperbulimia is becoming conjugated. The whole thing has been only unconjugated. Okay. Somebody has put in the chat box, can it be Crigler-Najjar syndrome? Excellent question. Excellent question. Can it be Crigler-Najjar? Absolutely right. I was coming to that. Two diseases you have not ruled out. One is Crigler-Najjar, other is the cousin of Crigler-Najjar. What is the cousin of Crigler-Najjar?
Gilbert syndrome.
Gilbert. Can this be Crigler-Najjar or Gilbert?
Yes, sir. Very well. It
Can very well be. Can very well be. In fact, I was just waiting for you to say that this should have come top in the diagnosis. Because there doesn't seem to be any anemia. Baby is thriving well. Okay.
Yes, sir.
It is non-hemolytic, unconjugated hyperuremia without anemia, without illness. Okay. Your first diagnosis itself should have been Crigler-Najjar or Gilbert, followed by all other conditions. I was just waiting very patiently as Akshay, and somebody, I must compliment whoever has put it in the chat box. Okay, quite rightly. This could well be Crigler-Najjar or Gilbert syndrome. Either. Only thing is, Gilbert syndrome presenting with such severe unconjugated hyperuremia, rather uncommon when compared to your Crigler-Najjar. Okay.
Yes, sir.
Right. Crigler-Najjar is very much likely, and as you know, Crigler-Najjar has got two types. What is the difference between type 1 and type 2?
Type 1, there is complete absence of UGTPA1 gene, whereas in type 2,
that's the one which is prone to cause cardiac arrest. Second one is rather mild, and you cannot distinguish clinically between Gilbert and Crigler-Najjar.
Yes,
right? And Crigler-Najjar mode of inheritance?
Autosomal recessive.
Autosomal recessive. Okay, right.
Yes,
the other conditions like, hemolysis being caused by, rare disorders like paroxysmal nocturnal hemoglobinuria and other hemopathy is very, very unlikely. Okay, right? Okay.
Yes, sir.
Go ahead. Please go ahead for examination.
Okay. Examination, baby was alert, active, and fed just 30 minutes back. Baby moves all limbs, cries normally, activity is good, tone is normal. Appears citric, lemon yellowish in color up to arms and thigh level. Pallor is present. Temperature was normal.
How did you make out?
All the vitals are normal.
Wait, doctor. Please go to the previous slide. How did you make out pallor in the baby?
On top of icterus, it's very difficult to find.
You have mentioned pallor percent. How did you make out?
But seeing the nail bed, the oral mucosa.
To me, the lips appear quite pink. Okay, the best way to look for pallor is the conjunctiva and also the palmar creases. That is where you should look for pallor. In addition to looking at the skin of the baby, right?
Okay.
You should also look at the tongue. Palmar creases and conjunctiva are the best places to look for pallor.
Yes.
But of course, with this photograph, I wouldn't say it is pale. Definitely, jaundice is made out. Lips appear reasonably pink, but very deceptive. Right, go ahead.
The birth weight was 2890 grams, and the present weight on 30th day of life was 3670 grams. Length was 50 centimeter. Head circumference and chest circumference were normal. OFC was 36 centimeters. On head-to-toe examination, head appears normal. No caput.
Go back to the previous slide. Head circumference, what is the head circumference? 36. Centile?
Between 50 and 75.
Always put the centile whenever you talk about it. Okay?
Sure.
And
okay.
preferably, if the mark plotted everything in a growth chart and shown, make it a habit.
Okay, sir. Okay.
Go ahead.
Head appears normal, no caput succedaneum or cephalometoma. Anterior and posterior fontanelle were open and at level. Face, there was no obvious dysformism. Eyes, there were yellowish discoloration of the sclera. Ear and nose were normal.
Did you look at the sclera of the baby?
It was a 30-day child, so obviously eyes were open, so I could find the sclera.
Okay. No, I'm saying the whole thing is caroteniemia. You agree or disagree? I'm saying this is not hyperbilirubinemia, this is caroteniemia. You agree or disagree?
An exclusively breastfed baby developing carotenemia.
No. That's not. I am saying this is keratonemia. This is not jaundice at all. Anybody can put in the chat box. Basically, you must remember
Carotenemia won't affect the sclera.
Never involves the sclera or the mucous membranes. Okay. And once you find keratonemia in a newborn, which condition, which is the diagnosis you should always think of? Keratonemia in the newborn. Anybody can put in the chat box. Hypothyroidism. Hypothyroidism is one of the common causes of keratonemia in a young infant or an older child. Right? Please think of hypothyroidism in your clinic whenever you see an infant with keratonemia and not jaundice. Of course, in keratonemia, you never get any involvement with the sclera. Okay, go ahead.
Umbilical stem was detached. There is no discharge from or around the umbilicus. Skin appears citric, lemon yellowish in color, present throughout the body, sparing palms and soles. Genitalia of female and appears normal. On CNS examination, child was not lethargic, no hypotonia, no high-pitched cry, no seizures, opistotonus or any posturing. Morose reflex was present and was complete. Normal start and response was seen. Sucking and rooting were present. Asymmetric tonic neck reflex was present. Palmar grist was strong and present. Upon abdominal examination, in inspection,
Nothing in abdomen you found out, nothing enough.
no,
2 centimeters normal, spleen not
normal.
Distension, no ascites, okay, no organomegaly. Go ahead.
And other system were also normal.
Okay. Give us some, see, always in the examination, make it a good habit, make a good habit of summarizing the history and physical examination in one sentence and giving a probable diagnosis. Can you sum up the entire history and physical examination in one sentence and give a diagnosis?
A term female child presenting with neonatal hyperbilirubinemia from day one of life, with proper well-to-do baby, with adequate weight gain and exclusively breastfed, without any significant findings on examination. Most likely a neonatal hyperbilirubinemia, pathological in nature, with no features suggestive of acute bilirubin encephalopathy.
How did you arrive at a BAIN score of 0?
So feeding was adequate, child had no lethargy, anterior fontanelle was at level, and no abnormal posturing, no seizure.
Very good, very good, very good. Okay, go ahead. So what do you think is the most likely diagnosis?
Most likely it would be a Crickler-Nazar syndrome, Gilbert syndrome.
Then why did you put hemolysis on top of it?
So rarer causes like
you should have clearly mentioned that this hyperbilirubinemia is unconjugated.
yes,
okay, unconjugated. Once if you had put unconjugated, and you should have also added that adjective without anemia, straight away ruling out a hemolytic anemia causing hyperbilirubinemia. It's a pathological unconjugated hyperbilirubinemia, which is unconjugated without signs of bilirubin encephalopathy.
Okay.
Right? And in an otherwise well infant who is thriving well, that's what you should have mentioned. And who is exclusively breastfed.
Okay.
Right? So if that you had mentioned, your first diagnosis would have been, what is your first diagnosis now?
Crickler-Nazar or Gilbert syndrome.
Type 1 or type 2?
Type 2.
Type 2. Type 2. Okay.
Yes,
right? Then only all other things will come. Then remaining differential diagnosis is only Gilbert. All other diagnoses are now disappear when the baby is well, when the baby doesn't have organomegaly or anything. Okay?
Okay.
Let me leave it to Dr. SEEMA before I come back. Dr. SEEMA, please go ahead. Dr. SEEMA, please.
Yes, sir.
Yeah, you can ask him. Yes, madam.
Yeah. Sir, so differential diagnosis already we have discussed, sir. So should we move ahead, sir? Because I don't think, because we have already discussed all DDs, sir.
Okay, okay, okay. Now, what do you do for this child? Now,
I would like,
before we go on to the action plan for this child,
yes, sir.
What
now,
investigate?
what are the common and uncommon causes of prolonged jaundice? And when do you use the term prolonged jaundice in the newborn period?
The jaundice extends beyond 2 weeks in a term.
Beyond 2 weeks.
Neonatal.
Beyond, by definition, for clinical purposes, any hyperbulimia which is persisting beyond 2 weeks, we always call it as
Prolonged jaundice.
prolonged. Okay. What are the common causes? What are the
Inadequacy of
red flags? What are the common causes and what are the red flags?
inadequacy of breastfeeding, like breastfeeding jaundice, breast milk jaundice,
Okay.
cholestasis,
Okay.
ongoing hemolysis like RHAVO, G6PD deficiency
Okay.
are the usual common causes.
Okay. See, first, always to the answer for that question, you should always say it can be divided into unconjugated, unconjugated. And you should mention all unconjugated are pathological. That's how you should start. You
All
get my
conjugated are pathological.
Dr. Akshay, you get my point?
Yes, sir. Yes.
Yeah. You should classify it into unconjugated and conjugated and straight away make a strong statement that all unconjugated are pathological. You cannot have conjugated hyperbulimia which is physiological.
Yes, sir.
On the other hand, you can have unconjugated hyperbulimia which is physiological, which includes breast milk, prolonged physiological jaundice, etc. Right? And
Yes, sir.
once you have a conjugated hyperbulimia beyond 14 days, the most important diagnosis that you should make very fast is, can you complete the statement? The most important diagnosis which you should make fast is biliary atresia. Very simple, biliary atresia. Okay?
Okay. Okay.
Reason is, if you do not operate before 3 months or earlier than 2 months, the long-term prognosis is going to become bad.
Okay.
So, yellow alert. You should pick up the conjugated hyperemia as fast as possible. Okay. In unconjugated, sometimes there may be an emergency if there is severe hemolysis with anemia, which can lead to cardiac failure and death. Right? In fact, very early such anemias can even cause hydrox fetalis cardiac failure.
Yes.
Whereas in conjugated, you have to act before you lose time for intervention for biliary atresia.
Yes, sir.
And once you have an unconjugated hyperbulimia, it is imperative that you should rule out hypothyroidism definitely quickly. The reason is, if you do not supplement thyroxine within the first 30 days, the future potential for normal neurological development is impaired.
Yes, sir.
So you should act fast. Right? And the next important step, whether it is conjugated or unconjugated, is to think of an infection. When I say infection, either it may be an intrauterine infection, which can have stigmata like microcephaly, deafness, organomegaly, thrombocytopenia, purpura, rashes, cardiac defects, right? And
Yes, sir.
eye abnormalities, which can give a clue to the presence of intrauterine infections like cytomegalovirus or rubella. Because toxoplasmosis more often causes hydrocephalus.
Yes, sir.
Syphilis can cause either hydrocephalus or microcephalus. Both can come. Because HIV is known to cause microcephalus. Right?
Yes, sir.
Then acute infection, any sepsis, particularly occult urinary infection, can always cause conjugated hyperbilirubinemia. Herpes simplex disseminated infection can cause hyperbilirubinemia. Right? So these are all the conditions you should quickly assess, analyze, and identify hemolysis fast.
Yes, sir.
Right? Then
Yes, sir.
proceed to investigate.
Okay, sir.
What do you do for this child? Having made a possible differential diagnosis of Crigler-Najjar, what do you do for this child?
I would like to confirm it by genetic study.
Okay. What are the investigations that you will do, and what reports did you get?
We have sent for UGT1A1 gene sequencing by PCR.
Start from go back to the previous slide. Start from the
Yes, sir.
basics. So what are the basic investigations you do for this baby?
Blood group, it turned out to be B positive, so we ruled out all that previously, sir.
Okay.
Total serum bilirubin was 16 point.
This tells you that this is unconjugated hyperbilirubinemia. Okay.
Yes, sir, without any hemolysis features.
7, that's straight away ruling out
Anemia.
hemolytic jaundice. Hemolytic
Yes, sir.
jaundice. Okay. Counts are normal, platelets are normal. Okay, right. Go ahead.
Peripheral smear was normal, retic was normal, Coombs was negative. We did a thyroid function test, it was normal.
Wait, 1 minute. Go to the Coombs test. What are the types of Coombs tests you know of?
Direct and indirect Coombs test, sir.
What is Coombs test? What is the difference between direct and indirect Coombs test?
Coombs test indicates immune reaction in the blood.
No. See, there are two types of Coombs test. What is the basic principle of Coombs test? What are the types of Coombs test? What is the difference between direct and indirect? That's my question to you.
Direct looks for antibodies that are stuck to the RBCs, whereas indirect looks for antibodies floating in the blood serum.
Excellent. The ones attached to the RBCs are identified by the direct. The ones which are circulating are identified by the indirect. Excellent. Right. So you direct Coombs test, you did this negative. Go ahead.
Thyroid function test was normal. G6PD, there was no deficiency detected. We did a TORCH profile of the child. IgM was negative.
Why did you do G6PD for a female infant? That too when hemoglobin is normal. Is it rational? You are wasting money. You should not be doing it. There is nothing to suggest hemolysis. There is no peripheral smear evidence of hemolysis. Retic count is normal. And anemia is not there. There is no female infant. There is no point in doing G6PD. Okay? Right. Why did you do TORCH profile? What is TORCH profile? Why did you do TORCH profile? What are the limitations of TORCH profile?
TORCH can also be a cause of prolonged persistent jaundice.
Pardon?
TORCH infection in the neonate can also be a cause of persistent jaundice. But usually it is a mixed picture of direct and indirect.
Understood my question. What are the tests you did for TORCH profile? What are the advantages and disadvantages of asking for a TORCH profile? What is the current status of TORCH profile today in 2023? These are my long questions to you.
We looked for IgM and IgG antibodies against Toxoplasma rubella, cytomegalovirus, and herpes simplex. Among that, only IgG turned out to be positive, which means there was past infection, and IgM, which indicates the recent infection, was negative.
First of all, you must remember today in 2023, if you want, you can even quote me. The so-called torch testing, torch titers, they are useless. They have no value today.
Okay.
Okay.
Yes.
The reasons are, today we have facilities to identify the so-called torch infections with better testing than testing of IgM or IgG. I'll tell you why.
Yes, sir.
Take, for example, cytomegalovirus.
Yes, sir.
Okay. The presence of IgG, like in this case, cytomegalovirus, doesn't mean anything. Similarly, IgM positivity for cytomegalovirus is again a useless test. Today, if you want to diagnose congenital cytomegalovirus infection, what is the screening test you will do? Can anybody put in the chat box? You want to diagnose congenital cytomegalovirus infection. What is the screening test you do? Anybody?
PCR testing.
Urinary PCR, CMV, qualitative PCR is a very reliable screening test for CMV, congenital CMV. If the urine PCR is positive, to identify the viral load, you can do blood quantitative PCR. So diagnosing cytomegalovirus infection using IgM and IgG antibodies is outdated. Number one. Number two, HSV diagnosis by IgG or IgM has now gone into dustbin. HSV PCR from the blood or from the CSF or from the skin vesicles is a reliable test for diagnosis of HSV infections, acquired or congenital. Rubella, again PCR is today available, is more reliable than IgM. And IgG for rubella doesn't mean anything. Today, there is no point in using the kits which are available for performing IgM and IgG antibodies for torch. Dr. Akshay, is my message clear and loud?
Yes, sir. Yes, sir. Clear, sir.
Of course, if you want to do, you should include HIV and VDRL also as part of the workup.
Okay.
Right?
Yes, sir.
Okay. If it is your Krigler-Najjar or if it is unconjugated hyperglycemia, in addition to all this, because you have mentioned thyroid test, right?
Yes, sir.
Yeah, you have completed the workup and you will ask for what is that UGTIA1 gene sequencing?
UGT glucuronide transferase.
Yeah.
A1 segmenting.
You send the sample for studies. Okay.
Yes,
Okay. Right. Any other investigation you do for this child? There's something very important in terms of prognosis of the child. I would have definitely done something. Don't mention you won't get full marks in the exam. Anybody can put in the chat box. In terms of complications of hyperbulimia, some tests. Do you hear my question?
Hearing,
Yes, yes, sir.
Hearing.
hearing.
Either you do autoacoustic emission or BERA for this infant, because you have to pick up deafness secondary to hyperbilirubinemia.
Yes.
So BERA or your what do you call it?
Autoacoustic emission.
Autoacoustic emission should be performed in this infant. Okay, that's what
Yes,
you
sir.
should. That's what you should perform. Of course, for completion, you should even ask for an ophthalmologist to look for any chorioretinitis as evidence of intrauterine infection.
Yes,
Okay,
Yes,
right.
sir.
Yes, madam. Madam, Dr. SEEMA Jain, you want to
Yes,
ask?
sir. Absolutely, sir. So
Go
even
ahead.
yeah.
Go ahead. Go ahead. We have time. We have all the time in the world. Go ahead. You want to ask any questions, madam?
No questions, sir, right now.
Okay, right. How are you going to treat this child? How do you plan to treat this child? Somebody has put very
Yes.
lightly in the chat box. How are you going to treat this child?
Since it's a Crigler-Najjar type 2,
Hmm.
which is usually not severe, doesn't usually cause kernicterus or bine, then I would like to reduce the serum bilirubin level by giving phototherapy since it's not in exchange range.
Yeah, somebody has put phenobarbital. Will you give phenobarbital? And
Yes,
what
sir.
is the
In type
mode
2,
of action of
we can,
phenobarbital? What is the mode of action of phenobarbital? When do you give phenobarbital?
in Crigler-Najjar type 2, we can give phenobarbital since the gene for the enzyme is present. Phenobarbital is an enzyme inducer.
It's an enzyme inducer. Its role is controversial. You can temporarily give it, but in severe cases, you may prevent kernicterus occurring by giving phenobarbital. At the same time, there may be a disadvantage of phenobarbital causing drowsiness, lethargy in the baby.
Yes, sir.
Okay,
Yes.
right. What is the mode of inheritance of this child you expect?
Autosomal recessive.
What is the genetic counseling? This is the first child. What are you going to tell the mother? What is the counseling that you do to the family? What is the counseling that you do to the family?
Since it being autosomal recessive, I would tell the mother there is 50% chance of the disease being
How much?
occurring in the
How much? How much? How much? What is it? Suppose the mother is pregnant again after 1 year and comes to you. What is the risk of recurrence of this? What is the risk?
50.
25%. Yeah, it is an autosomal recessive disorder. It's only 25%. There is a 25%. See, there are two concepts you must remember. If it is an autosomal recessive disorder, there is a 25% chance of recurrence of the same disease, irrespective of the sex of the child. If it is an autosomal, when you say 25% risk, it is not that if the mother gives birth to 100 children, 25 will get. For every pregnancy, there is the risk of 25%. That is what is important for you to remember. Similarly, if it is an autosomal dominant disorder, there is a 50% risk of recurrence of this, irrespective of the sex of the individual. If it is an X-linked recessive disorder, what is the risk? Like, for example, hemophilia. Yeah, somebody has put correctly in each conception. Yes, good. If it is X-linked recessive disorder like hemophilia, you have a child with hemophilia, boy, mother has got a boy, she becomes pregnant. What is the risk you will counsel?
Every male child has.
Every male child has got a risk of 50%. And every female child has got a risk of becoming a carrier 50%. That's what you should mention. Okay?
Okay.
50% risk for every male to have the disease, 50% risk for every female to become a carrier.
Okay.
Okay? You
Okay.
should do. You should do. And okay. Madam Seema, you want to ask any more questions?
Yes, what is the ultimate treatment for Crigler-Najjar? Long term.
Gene therapy. We have to replace the defective gene.
Yeah, liver transplantation.
Liver transplant.
Okay.
Madam, if you know the case, you can ask more questions.
Ji, sir.
Okay, Akshay,
Yes.
just one differential diagnosis of your slide पे जाइए. Can you go back to differential diagnosis? In the first point, first differential diagnosis, you put at hemolysis.
Yes, sir.
Why so?
So causes like hereditary spherocytosis, which couldn't be ruled out from history and
But
examination.
was it after history or was this after examination?
After examination.
So what? This was after examination. Okay.
Yes, sir.
So hemolysis, there was no other evidence, like no in the newborn like hepatosplenomegaly. This after even you have done the investigations already?
No, sir. This was before doing investigation.
Okay, so if any other evidence is there, then we could have considered hemolysis, like liver, spleen, or suspicion of, they say,
Pallor.
family history. Okay. So much of jaundice difficult to make out pallor, as sir said. But anyway, this may not be the first. You could have put this in the second or third, maybe. That's what I feel.
Yes, yes, yes.
You are right, Motwani. Putting hemolysis as the first possible diagnosis, but we corrected it when the discussion also.
Yeah.
In the absence of hepatosplenomegaly and severe anemia, hemolytic jaundice is not a possibility at all in this infant. Okay, it's non-hemolytic congenital hyperbilirubinemia, unconjugated hyperbilirubinemia.
Yes, sir.
That is your complete diagnosis.
Yes, sir.
What is the prognosis for this infant?
Prognosis is very good since being type 2 and insulin.
It should be good. How long can you give phototherapy? Up to what age you can give phototherapy? Up to what age you can give phototherapy?
That's no clear-cut definition as such, sir, but up to 6 to 7 years is advised.
Yeah, though in older children, because of the thickness of the skin, the permeability of the ultraviolet rays is not going to be good. Effectiveness of phototherapy may be inferior, but you can give in older children also.
Okay.
Okay, particularly in older infants, it can be still used.
Okay.
Okay. Madam, any other comments from you? Motwani, anybody else wants to make any comments?
Yeah. Any doubts? All the postgraduates you can ask now.
Actually, you can close these slides and open your video. You can stop sharing your screen. Please stop sharing the screen. In fact, for a change, I like this case for the simple reason, most of the time students present your cholestatic jaundice and biliary atresia. For a change, Dr. Akshay today presented a non-hemolytic, okay, unconjugated hyperbilirubinemia. Thank you, Dr. Akshay. You presented very well. Let me wish you all the best. My blessings to you. Over to Motwani and Dr. SEEMA J.
Akshay, can you just tell me what can be the probable causes of recurrent jaundice? Like right now we have discussed about prolonged unconjugated hyperbilirubinemia. Then we have discussed about like conjugated hyperbilirubinemia. So what can be the probable cause for recurrent jaundice?
Untreated congenital hypothyroidism.
Sorry?
Congenital hypothyroidism being untreated.
So that will be prolonged jaundice mostly. Unconjugated and conjugated later.
Yes.
So only condition, Gilbert syndrome. I have seen one case, one adult male who used to come with
Dr.
recurrent
Akshay,
jaundice.
please stop sharing the screen. Stop sharing.
Neonatal period may recurrent jaundice, even I have no experience.
Akshay, stop sharing the screen. Please stop sharing the screen. Please go ahead, madam. Please stop sharing the screen. Yeah.
Yes, sir, looking.
No, still there.
Yeah, Akshay, please stop sharing the screen.
Hello.
Yes, sir. Yes.
He's trying to stop.
Yeah.
He's not able to close that window.
Okay, go ahead, madam.
Yes, sir. Yeah,
not...
sir, only few cases which we have seen, cases of recurrent jaundice, especially in adults, what we have seen, one Gilbert, cholelithiasis, or conjugated. Cholelithiasis may present as conjugated hyperbilirubinemia, but that is not so commonly seen. But Gilbert syndromes I have seen in an adult who presented with recurrent jaundice. He had off and on waning vaccine phases of jaundice. So therefore, I just happened to ask what can be the probable causes of recurrent jaundice.
Recurrent jaundice can occur, for example, in G6PD deficiency on exposure to medication. In fact,
Drugs, medication.
I know that's probably the most common recurrent jaundice. In fact, I know a boy who's now 16 years old, whom I am following up from 1 year of age. He has G6PD deficiency. He will develop hyperhemolysis and jaundice and anemia, even with paracetamol. He doesn't tolerate even paracetamol. Nothing worse. Ibuprofen we have tried. Everything causes hemolysis. Poor fellow, 16-year-old, and he's managing to survive intellectually well. That is one. Second is, as you rightly put, benign recurrent cholestasis is one disease. Benign recurrent cholestasis is well described. Some of the bile acid metabolisms can cause recurrent jaundice. Cholelithiasis, you rightly said. And even some types of choledocal cysts can fool us. Choledocal can fool us with recurrent jaundice. And
sir,
of course,
in Chhattisgarh, sir, we have recurrent. This is basically sickle cell disease and thalassemia. Mostly sickle cell disease leading to recurrent jaundice.
That can happen.
Yeah.
And
malaria, infection, malaria, not recurrent, but
malaria. Of course, in South we don't see malaria at all. You will all be seeing, and we don't see malaria at all. That too, as a cause for jaundice, we don't see. But theoretically, falciparum, yes, can cause recurrent jaundice. It can even cause malarial hepatitis. That's rather unusual. Okay. Okay, Motwani, anything else you want to add? Any other questions from the students? There is anything, we can try to take it up. Otherwise,
if there are no more questions, then I think we can conclude the session. So, Dr. Akshay, really nice case presentation. It was interesting case of newborn with prolonged jaundice. I thank you very much for your nice case presentation. And I thank our experts, Dr. S. Balasubramanian sir and Dr. SEEMA JAIN, for adding very valuable inputs. It was really an interesting discussion on this case of newborn with prolonged jaundice. And I thank all our senior pediatricians from across the state. Ventric sir is there, and Dr. Tamrakar sir there, Srikant Giri and Ganesh Mishra, everyone who has joined this, and of course all the postgraduates who have joined this webinar, PG Clinics, and made it successful. Thank you so much, everyone, and good night.
Okay.
Thank you, sir. Thank you. Good night. Thank you, madam. Good night.
Thank you, sir. Yeah, thank you, Dr. Naresh Motwani.
Thanks, Dr. Akshay.
Madam, thank you.
Good night, sir. Thank you.
Good night. Yeah.